Okay.
Yeah.
Yeah.
1 minute. Okay. At the outset, I'd like to thank Dr. Namrata and the AOAs for giving me this opportunity. So I'm just going to quickly go through some of the situations where we're going to have difficulty when you're combining phacoemulsification with a corneal problem. So any local cause such as pterygium, sphenoidal degeneration, keratoconus, systemic diseases that can affect the cornea like collagen vascular disorder, post-refractive surgery, a previously operated eye, and of course an endothelial problem could also be are some of the problems that we can face. So the pre-op evaluation, the pearls would be documentation of the corneal pathology is very important, specular microscopy in case of endothelial disease, systemic evaluation, particularly collagen vascular disorders, and pachymetry to determine whether the patient needs a combined procedure or not, and corneal biomechanics and topography in patients with keratoconus and PMD for determining the toric IOL power calculation. So the most important thing in a combined problem is that you have to inform the patient that it's not the cataract which is alone causing the drop in vision, but because of some of the compromised cornea, you're also having defective vision. So this is a very important thing that you have to emphasize to the patient and also tell them the risks involved in compromised corneas, the difficulties during surgery, and the prognosis of the outcome. So there are several problems as simple as epithelial problems like EBMD, dry eye, post-herpetic corneas, patients with Bell's palsy with exposure keratitis, post-archic corneas, post-PK corneas, Fuchs dystrophy, and keratoconus. Herpetic corneas, we all know it's better to avoid during active ulceration. And the most important thing in these patients is to prevent recurrence because post-operative use of steroids can always cause a recurrence. So good lubrication and antiviral prophylaxis may be required, and particularly in patients who have recurrent incidences. So Bell's palsy again is a problem because of the poor lid closure. You can see that already the cornea is very much damaged. So it's important either you do a lateral tarsography before and improve the health of the cornea. You can remove the lateral tarsography during the procedure, during the cataract procedure, and then retape or advise patient to tape or redo the tarsography post cataract surgery. But the most important thing is that you have to take care of the cornea before. Corneal scars are a problem because you know that the cataract has to be done and you know the opacity has to come out. So it's a combined procedure is definitely needed. So what type of IOL power calculation that you're going to do will be the most challenging thing. Either you can use a keratometry from the other eye, but most of us prefer to use an average of 43 or 44 diopters. But if the cataract can wait, then you can go ahead with a keratoplasty is the first stage and stage your cataract a little bit later so that you will have some amount of idea about the keratometry of the cornea. So this is one of my patients who had a 14 diopter after a DALC for a keratoconus, and after suture removal, she dropped to 7 diopters, and she needed a customized IOL. And the most important thing is that in post-PK or DALC surgery, maintaining the post-operative clarity of the graft is also very important. So good viscoelastics need to be used. Ocular surface compromise, anything which can cause corneal anesthesia, such as immune ulcers, contact lens abuse, topical drug toxicity, neurotrophic dry eye, have to be dealt with before taking up the patient for cataract surgery. So rheumatology opinion, control of systemic parameters, the need for long-term steroids, and the care about NSAIDs and discussing with the patient the need for frequent follow-up is very important before taking up these patients. You can see the ocular surface, which is very badly damaged, which needs to be improved before taking up the patient for cataract surgery. As far as endothelial disease is concerned, this is something which we come across very often. So the question is whether we do a combined surgery or just go ahead with a cataract alone. It depends upon the amount of involvement of the endothelium. So if you're just doing a cataract surgery, use abundant viscoelastic, use a soft shell technique, a low phaco power and whole phaco techniques. You can do an SIC as an ECC in very hard cataracts. However, if you're doing a combined surgery, usually the decision is made upon how how symptomatic the patient is, the amount of blurring, whether the pachymetry is more than 600 microns, presence of bulle or epithelial edema, and also the density of the cataract. If the cataract is very dense, you know that the patient is going to lose more endothelial cells, and it's better to do a combined surgery. So we all know the routine phaco loss is 6.3 to 12.8%. So taking care to make sure that when you're doing a routine cataract surgery in a patient with endothelial cell compromise, you do a in the bag phaco and use a high density viscoelastic and a soft shell technique and use cold phaco technology to reduce endothelial cell loss. So other considerations are scleral tunnel incisions and avoid patients, just make sure that patients who have other problems such as EBMD and anterior corneal dystrophies should be taken care of. So this is one of my patients who had a DSEK in a Fuchs endothelial dystrophy. You see how beautifully the epithelium has come off. And once epitheliorhexis has been done, you can see a very clear anterior chamber. You can visualize the lens very nicely. And you can go ahead with a phaco, routine phaco. You don't really have to worry about the endothelium in this case because I'm going to do an lamellar transplant. And we can actually use a trypan blue because it gives better visualization. And in this case, I've not used it. And gentle phacoemulsification. You don't want to have any complications in these procedures because you're planning a triple procedure. You just want to make sure that everything goes on well. And I use an anterior chamber chopping technique. I chop in multiple pieces and then I emulsify all the pieces one by one. I don't remove the pieces as we chop, and that is usually my technique. And once it is done, I do an IA. And fortunately, you can see that the visualization is excellent in this patient after removing the epithelium. And then you implant a lens, intraocular lens in the bag. So in these patients, the next stage would be to mark the center of the cornea so that you make sure that that you're well-centered, your graft is centered. Use a reverse Sinski to score the endothelium all around. And you can keep the pupils dilated because then you can see very nicely how the endothelium is peeling off. In patients who have Fuchs, usually it peels off very nicely, a single piece. It's like more like a desmetorexis, and it comes out very nicely. But in patients who have PBK, usually there'll be a lot of scarring and it'll be difficult to get them out in one single piece, like you see here. And once the endothelium is removed, completely remove the viscoelastic. Go under the lens, remove the viscoelastic, and make sure there's no viscoelastic remnant. Do a small PI, inferior PI, because you're going to fill the bag with air. And my technique of doing a DSEK is a push through technique. Here I'm using a sheets glide to keep the cornea, the disc of the cornea, which has been prepared already. So the top layer is removed and only the endothelium with a little bit of stroma is remaining behind. And I'm using a 26 gauge needle to do a push through technique. And you come out very gently, inject saline through the side port, and you can see that the graft is unfolding very nicely, and then inject air. It's always better to go to the center and inject, then the graft does not slip to the slides like what is done. You can use a reverse Sinski to center the graft and fill it up with air. This is a post-operative outcome of this patient. As you can see, a very clear graft in about a week's time. So this is again a patient, you can see a localized corneal edema, again a patient with Fuchs, a combined surgery. Most often when you do a combined surgery, like this talk demands a phaco with, this is the indication is mainly Fuchs, because we don't, all the other indications are usually pseudophakic bullous keratopathy where the lens has already been removed. And that's why I have to show you another case of Fuchs. So this cataract has come out very nicely. This is even in patients who have very early cataracts like this, as you can see here, probably grade 1, which probably wouldn't be operating. It's better to remove them because you don't want to go inside once the graft is in place, because you don't want any more endothelial cell loss. So it is better, unless the patient is a very young patient, has an absolutely clear lens, then you can do a DSEK without removing the lens. So here again, you're getting a nice red glow, and you can see that the margin of the endothelium being stripped off very nicely. You can visualize it, and I prefer to do it under viscoelastic because it gives us better control. The AC does not shallow. You can also do it under air because it also gives good visualization, and you can just come out very nicely. It's a single piece. And then again, you go inside and remove all the viscoelastic completely, and then inject air. I'm doing a PI, inferior PI, and again, a push through technique, inject a saline, and that's the end of the case.
I'm short again.
Yeah. So this is again another patient, uh, another patient with who needed a Phaco DSEK with hard cataract and a small pupil. So I went ahead and did a Phaco, as you can see. Patient had a very floppy iris, but that's why I had to put a pre-placed sutures. Ultimately, the patient turned out very well. I have about 6-year follow-up on this patient. So these are some of the problems that you don't anticipate, because I didn't expect the patient to have a floppy iris at all. But fortunately, everything went off very well, and the disc that came out very well, and the disc was unfolded beautifully, and the outcome was good. So these are some of our patients who had a Phaco DSEK. And the other things that we look for is another compromised cornea that we're speaking about is a radial keratotomy, where not only the biometry is difficult, but also the chance of wound gaping, particularly when the incisions are much more, like more than 8 incisions. It's going to be difficult to put your incisions, your side port incision or your main port incision can open out. The wound can gape, so it's very important to use adequate parameters, slow motion phaco, to make sure that the wound doesn't gape. And in post-LASIK patients, if the ablation is not well centered, it's always better to avoid multifocals. So I think my time is up. And to summarize, treat the ocular surface before cataract surgery, counsel the patient about the outcome. Post-keratoplasty, all sutures to be removed before cataract surgery probably gives the best results, but sometimes we may not be able to do it because the cataract matures much earlier than the sutures take up. So we may have to still do it. We go ahead and remove the cataract and do combined procedures whenever required. Thank you.
I think that was a wonderful talk, Dr. Sujatha Mohan.